This PowerPoint discusses care of the postpartum patient or client. We have several objectives, but mainly it is to identify the normals, and so then we can identify some of the abnormals, and if not, get help. In addition to that, we have postpartum assessments, which those of you who have already been in simulation got to experience some of that, and those of you who haven't will get that opportunity as well. In addition to that, this assessment is very important because remember we talked about the number one risk factor to our patient is hemorrhage, and the majority of hemorrhages that you will see is in the postpartum period. So it's important to know the normals so that we can identify those that are abnormal. When we talk about the postpartum client, we're talking about once there's so many changes that occur. Think about when a client is pregnant and her whole body is focused on a couple of things the minute she gets pregnant, is on making sure the baby needs what it gets to grow and also to prepare for delivery. And even some of the preparations that the body does to prepare for delivery is increase blood clotting factors so that the woman won't bleed to death at the time of birth. So there's all kinds of things that the body is doing to grow the baby, nurture that baby inside the uterus, and then also to prepare for delivery. And in that preparation, there's a couple of hormones that play a huge component in pregnancy. And one of that is progesterone, which maintains the pregnancy. And the other one is estrogen. What's interesting is that placenta continues to grow inside the uterus. The placenta is fully functioning by 20 weeks gestation, and it's fully functioning as an endocrine gland, and it's producing tons of progesterone and estrogen to maintain the pregnancy and to grow the fetus, among other hormones, but those are the two main ones. So you think about it, you've done 40 weeks of growing this beautiful baby with estrogen and progesterone maintaining the pregnancy. And then your body is also preparing by increasing blood clotting factors, all for this day, the miraculous day of delivery. So we've learned a lot already. We've learned about the process of labor. We've learned about delivery. That would be all the dilating, which is stage 1. The delivery and pushing is 2. We learned about the delivery of the placenta, which is stage 3. And really that's when the postpartum period begins, is after the delivery of the placenta, because after that delivery of the placenta, everything switches over. That placenta comes out, and remember that placenta was supplying tons of estrogen and progesterone to maintain and grow the fetus. Now it's out, and now the body goes into a full different mode. The mode that it goes into is stop the bleeding and make milk to feed the baby. So it's again survival of the baby by making sure that your body produces the colostrum and the milk and everything else to feed the baby, but also to save the patient from bleeding to death. So it's funny. It's not funny. It's really miraculous how once that placenta is delivered, everything changes. Okay. So now instead of estrogen and progesterone being produced by the placenta, the body starts producing lots of pitocin or oxytocin. And oxytocin is the hormone that makes the uterus contract. And that is so important because the uterus needs to contract right after delivery to constrict the blood vessels to prevent bleeding. In addition to that, the body is also going to produce prolactin. And prolactin is actually the hormone that has to do with making of the milk. In addition to that, oxytocin is also the hormone that actually releases the milk when the baby sucks. And we'll talk a little bit more about that when we talk about breastfeeding. It's amazing how immediately after that baby is born, the top of the fundus or the uterus was way up high, right underneath the rib, right underneath the breasts, high up on top of the rib cage. Right after that baby is born, the baby drops to about the level, the fundus drops to the level of the umbilicus, meaning the baby is out now. So the top of the fundus has dropped down to the umbilicus. And interesting enough, that is about the size the uterus is when the baby is 20 weeks gestation. It's right at the umbilicus. And one of the ways we can do that, and we'll learn that when we talk about prenatal history, is that we actually measure the height of the fundus in prenatal to see if the baby is right on for gestational age, and we'll talk about that later. But know that right after the baby's delivered, the top of the fundus is going to be at right around the umbilical level, and that's where it should be. Again, the decreased estrogen and progesterone levels will cause autolysis, or the breaking up of tissue. And all this is the process of involution, which is the uterus returning back to its normal self. Remember that the uterus, it took 40 weeks to grow the baby inside the uterus and to get ready for the delivery. We tell women it takes a good 6 weeks to go back into normal for you to fit back into your skinny jeans and those types of things. The body is miraculous, but it still takes some time to get back into the pre-pregnancy state. So here is the top of the uterus now. It's right about the umbilicus. It's constantly shrinking. And here you can see you've got the hand on the left hand of the provider that's showing you the size of the uterus right after delivery and the position. So it's right around the umbilicus. And it's, yes, and so that's the size that you will see right after delivery. Here's 2 days postpartum. It's 2 fingers below the umbilicus. She's doing a fundal check, which is she's providing some support with that left hand as she massages and checks the placement of that uterus. It should feel nice and firm, kind of like an orange or a lemon. On a thin patient, it's very easy to palpate. On somebody who has a little bit more adipose tissue or who's a little fluffy, you have to dig a little deeper to find that uterus underneath the adipose tissue. But here you can see she's found the top of that fundus, 2 fingers below the umbilicus. I would say when you're checking the fundus and doing a fundal check like she is, you would actually have this sheet below so that you could see as you massage what the bleeding is like. But probably for the sake of this particular slide and not to expose the patient, she's covered. But in a normal postpartum assessment, as you massage the uterus, you would look to see what the bleeding is like. This is 4 days postpartum. Look at the size of the uterus, how fast that body is adjusting to the postpartum period, and it's shrinking just as it should be to stop the bleeding. It's constricting and everything else. It's really quite amazing. So here you can see how quickly that uterus will shrink by day 9. It's hardly palpable. It's almost, right down where it should be. Now, sometimes, though, when the bladder fills up, what it does is it displaces the top of the fundus, as you can see, kind of to the right and above the umbilicus. This is a problem because what happens is when it is displaced above the umbilicus and to the right, the uterus has a harder time doing what it's supposed to do, which is contract. If it can't contract, it cannot constrict the blood vessels, which can lead to excessive bleeding, and if it's not taken care of, can actually lead to a hemorrhage. We do not want women to lose any more blood than they have to. So it is really important that we keep those bladders empty. A patient who is delivered without an epidural can get up to the bathroom within 1 to 2 hours with assistance. A patient who has had an epidural, after you have to check to make sure that she can bend her knees and lift her bottom up off the bed, her hips. And if she can do that, she needs support to get up to the bathroom. She may have a little bit more trouble with that first void. And sometimes an epidural patient may need to be straight cathed a couple hours after delivery to prevent that fundus from going up above the umbilicus and to the right. So keeping that bladder empty is important in labor, but also important for postpartum to prevent uterine atony, which is a boggy uterus, meaning it's not constricting and blocking those blood vessels and constricting them so that the patient does bleed. Leads to excessive bleeding, which if you don't take care of it, can lead to a postpartum hemorrhage. To do a fundal check, you use one supporting hand on the suprapubic area, And then you, on the other hand, you actually find the position, where is that top of the fundus, and you gently massage it. If it's nice and firm, you don't have to massage very hard. The body is doing what it needs to do. If it is infirm and it's boggy and the patient is bleeding, your first nursing action would be to massage with some pressure to try to get it to start contracting and constricting those blood vessels. The fundal check is very important. Right after a patient delivers, we do a fundal check every 15 minutes for the first 1 to 2 hours, depending on the facility. Once they're up into the postpartum or couplet unit, we don't do them as often because most of the time we're going to have an immediate hemorrhage, which is in the first 2 hours. Doesn't mean it can happen after that, but we will still, the greater chances, most of the time after that 2 hours, we can tell the patient is going to be stabilized. And then again, paying attention to risk factors for hemorrhage as well. Well, we talk about how it is charted. In the electronic medical records, it's very easy because when it talks about where the uterus is, it's just a drop-down box. FF is just fundus is firm. So if the fundus is firm, is it at the umbilicus? Is it 1 finger below or 2 fingers below? And the width of 1 finger is 1 centimeter. Or it could be 1 above or 2 above the umbilicus. Usually right after delivery, it's going to be right around the umbilicus. It could be maybe a +1 or a -1, but it's going to be around the umbilicus. If it starts if your patient is bleeding, it starts filling up with blood, you're going to find it goes above the umbilicus. So if it's like a +2, +3, you're probably going to be having some bleeding because you need to get that uterus to start contracting so it constricts those blood vessels to stop the bleeding. So placement to find out where that uterus is and if it's firm is really, really important assessment, because again, what we're really concerned with is that patient contracting that uterus, and is it constricting the blood vessels so she does not bleed excessively and lead to a hemorrhage. Involution is the uterus going back to its pre-pregnancy state. Subinvolution is basically the failure of the uterus to return to the non-pregnant state. The most common causes are if any of those placenta parts are left inside the uterus, that patient can bleed, trying to get rid of it. That's why the doctor inspects that placenta right after delivery to make sure no pieces were left behind. And the other reason would be infection would cause the uterus not to be able to return to its pre-pregnancy state. Interesting enough, for that involution to occur, to return to its pre-pregnancy state, it's really achieved by the compression of the intramyometrial blood vessels. Basically, the blood vessels contracting or constricting as the uterus contracts. The body does its own work. It releases oxytocin from the posterior pituitary gland, which actually strengthens and coordinates uterine contractions. It's the same hormone that was released during labor to actually have contractions and push the baby out. There's a couple things that we do to make sure that that there's lots of pitocin to stimulate that uterus to contract postpartum. One of the things is if we put baby to breast right after birth, it actually stimulates oxytocin release. So one of our big initiatives is to promote breastfeeding within the first hour of life. It helps not only the baby to breastfeed because the baby is awake and alert and oriented and wanting to breastfeed usually within the first hour of life, but also it benefits the mom as well to make that uterus contract to stop bleeding. In addition to that, we know that postpartum hemorrhage is one of the major complications that can lead to mortality and morbidities of our patients. So we know that giving extra pitocin or man-made drugs of oxytocin, if we give that IV or IM in larger amounts, it's not going to hurt those who will not hemorrhage, but it can prevent those who might hemorrhage and actually prevent a postpartum hemorrhage. So it's routine protocol. Sometimes if you're delivering at home or in a birth center where you're very low risk, sometimes they'll just give you about 10 units IM. If you're in the hospital, you're probably going, almost everybody will have an IV, and they will get it IV through the IV. Usually the standard dose, every hospital is a little bit different, but usually they put about 30 units in a 500 cc bag. and give 150 milliliter bolus right after delivery, right after the placenta is out, and then 150 an hour for a couple of bags of that Pitocin. Every hospital is a little bit different. I don't expect you to memorize that, but just know that we give large amounts of Pitocin because we have found that it prevents postpartum hemorrhage and doesn't harm those who would not hemorrhage anyway. In medicine, sometimes we always give what is best for the whole. What are the normal vital signs right after delivery? Because not only are we going to do our fundal check and check for bleeding, but we also need to check the vital signs every 15 minutes. I would say the big thing we're watching for is that blood pressure. Most of the time, the blood pressure is going to be what it was pre-pregnancy, but sometimes when they first get up to the bathroom, they may have some orthostatic hypotension for about 48 hours. So usually we're going to be very careful when they sit up, ask them if they feel okay before standing up and assist them the first couple of times they get up to the bathroom. Temperature, usually in the first 24 hours, it may get up to 100.4 just because of dehydration and the effects of labor. But after 24 hours, it should be a normal temperature, and they should not have any temperature at all. So we have to keep an eye on that because we also know that one of the highest risk factors for our women not only is hemorrhage but also infection. Respirations and pulse should remain about the same as pre-delivery. We talked about how important it is for that uterus contract to constrict the blood vessels. Well, we just finished delivering a baby and those contractions were pretty painful. How painful are they for the postpartum patient? Normally after she delivers, she's so relieved and she's so happy to see her baby, but she's kind of tired of being messed with. So I think the postpartum checks, they're not so much painful, but they're annoying and they just don't want to be messed with anymore. I will say this, though, that it is really important that uterus contracts to constrict. Most first-time moms, though, that uterus doesn't have much difficulty because it's still very elastic and it's just like a balloon that's only been blown up once. It still has some elasticity, so it's easy for that uterus to contract. But I will say this, after the first baby, that uterus has to work harder to get back to its pre-pregnancy state. If the patient has had 5 babies, it has to work even harder to get back to its pre-pregnancy state. So therefore, the after-birth pains are going to be more painful probably for somebody who's had who's already on their second baby and beyond. The more distended the uterus was, if they had a large baby, that uterus has to work harder to go back to its pre-pregnancy state. So those people may feel more cramping after they deliver. When I say cramping, it's kind of like menstrual cramps. Some people will say it's mild, but some people actually need Motrin or something to help them with those discomforts. If they put the baby to the breast, remember that's producing more oxytocin, which is actually increasing the strength of those contractions. So those moms that are breastfeeding actually have more postpartum cramping or discomfort, which is a good thing because it's actually getting that uterus back into its pre-pregnancy state and actually decreasing the amount of bleeding and get you in those skinny jeans faster. But again, there's going to be more cramping after you've had your first baby, or if the uterus has been over distended because it has to work harder to get back to its pre-pregnancy state. Again, those breastfeeding moms may have more cramping. Again, we assess their pain level on a scale of 0 to 10. How much pain are you having? And again, if we need to, we can actually give them some ibuprofen for those discomforts. Just like with menstrual cramps during women's periods, the ibuprofen works very well. Now, what's interesting is when that placenta comes out, which begins the period of involution or the postpartum period, it's really interesting because that uterus really needs to dig into the uterine wall to get the blood supply to give to the baby. It has to dig in good enough so that we get a good supply of oxygen for the baby, but not too much so that it cannot detach. What's very interesting is there's a very unique healing process that prevents any scar formation on the uterus. It's the upward growth of the endometrium. And it's very important that no scar remains in the uterus, because when that woman wants to get pregnant again, when that the fertilized egg drops into the uterus to implant onto the uterine wall, it may, if there's any scar tissue, you may have abnormal placental attachment and growth. And so therefore, people think, oh, no big deal, but it's a huge deal that there's no scar tissue that remains in the unique healing when that placenta actually comes out in that third stage of labor. It's pretty amazing when you stop and think about everything that the body does and how kind of miraculous it is. So we know the assessments, we check the vital signs, we watch a little bit for orthostatic hypotension. That blood pressure also could be a late indicator if the patient is hemorrhaging. We check our fundal checks every 15 minutes. But when we do a fundal check, we also at the same time are checking to see how much bleeding there is. So we need to look at the pad, and sometimes that the blood will go underneath the patient. So we need to make sure we're looking underneath the patient to see if there's any pooling of blood. We call that post-birth uterine discharge lochia. And there's 3 types of lochia. Lochia rubra, which is the bright red bleeding that usually lasts 1 to 3 days. If you were in the clinical setting or in the hospital, that's what you would be seeing is the bright red lochia rubra. It's kind of like a period or a menstrual discharge where after it's bright red, it goes to serosa, which is a pinkish color, and sometimes it can even have some brownish, which means old blood. That's usually going to last anywhere from 4 to 10 days or a couple weeks postpartum. And then from there, it goes to lochia alba, which is just kind of a yellow to white, and it kind of has the mucus and serum and bacteria, and that can last up to 3 weeks. Some lochia may persist 4 to 8 weeks after birth, but the important thing is it's not going to be too much, and we're going to talk about what's normal and what's not. Sometimes with that bright red, sometimes we may see some small clots initially, and they should decrease. And if there are large clots, it could be a problem where they need massage and maybe that they're bleeding too much. But it's very important to assess where the fundus is and also the lochia as far as what color we need to chart. Of course, in the hospital, it's going to be lochia rubra and also the amount. This shows lochia, the amount. We have a scant amount on the first pad on the left. It goes to light amount, moderate, and heavy. If you look on the very right, you can see a saturated pad. It's really important to know what's too much bleeding. And in a postpartum patient, if the patient is saturating more than 1 pad an hour after that initial getting up to the bathroom and everything else where there's, because of gravity, you'll see it looks like a lot when they first stand up. But if they're saturating more than 1 pad an hour, then we need to check out why, because that's a little bit much. When they're discharged home, it's really important to educate them on what's too much. If they saturate a pad in 1 hour, put on another one, it's saturated within another hour, they need to call their healthcare provider. That's a little bit too much blood, and we don't want them to become anemic or go into a postpartum hemorrhage. I had a friend that became a nurse after she had her 3 kids. She said that when she was home, she started bleeding a lot. She wasn't sure why. She wasn't sure if it was too much. Her husband came home and she was lightheaded, so they went to the hospital. A couple of her stitches had come loose and she was actually actively bleeding. They did an H&H and found out she was borderline whether she needed blood or not. She chose not to have blood, but she went home and she was anemic, and she said it ruined her postpartum period because she was extremely tired. And she had her toddler and also a newborn baby to take care of. The sad thing is as she learned when she was a nurse, that this was totally preventable if somebody had told her what was too much when she went home. Whenever we do a postpartum assessment, it's very unique. It's different than the head-to-toe assessment of a medical surgical patient or neurological patient. Sometimes it's easy to think of acronyms to help us with our assessment. So a lot of times when we do our postpartum assessment, we can think of the acronym BUBBLE-HE. And BUBBLE-HE stands for B is for breasts. We have to assess the breasts. U is for uterus. B is for bladder. The other B is for bowel. L is for lochia. E is for episiotomy. H is for Hohmann sign. And the last E is for emotional status. So usually when you do an assessment, you start from the top to the bottom. I would say in this one, the very first one is breasts. And we stop and think about, why do we assess breasts in our postpartum period? We're assessing them really mainly to see if mom is breastfeeding okay and to actually educate her. There is so much to educate our parents on. When we assess, we educate. So you can really do the best time to assess the breasts is when mom is breastfeeding, if she is breastfeeding, and we highly encourage all our women, but some women choose not to, and then we can do those breast assessments anytime. If a patient is not breastfeeding, then we encourage no stimulation at all to the breast, because stimulation will cause milk production. So we have them wear a very tight bra with no stimulation. And sometimes they can put cabbage leaves on them. And that actually has decreases swelling, but we would warn them that it could cause some staining to their clothing. They used to give medication to dry up the milk. They found that hormonal medication was not good for the patient. Imagine that. And now they're going back to natural ways of drying up the breast, which is no stimulation, tight-fitting bra, and cabbage leaves. Now, assessment on a breastfeeding mom takes a little bit longer, particularly on a first-time mom, because as you're assessing, you're educating. What you're going to be charting on is, what does the nipple look like? Because the nipple has a lot to do with maybe how hard, difficult breastfeeding will be and how much education they need. There's 3 types of nipples. The one that is a good assessment would be an erect nipple, one that the baby can latch onto easily. But some nipples are flat, so it's harder for the baby to grab onto the nipple, and some are actually inverted. We can work with the nipple by stimulating it sometimes to bring out that nipple for it's easier for baby to latch onto. Sometimes we need to put on a little nipple shield, which is like a little plastic nipple over the areola, so that the baby has something to grab onto and the milk will still come. Again, you can see how if it's a flat or an inverted nipple, that patient would require more education. We do chart the status of the nipple. We also chart to see how well mom is breastfeeding. Is she confident? You know what I mean? Does she need assistance? Because if she needs any assistance at all, the chart is going to flag a lactation consultant, or else it will flag you to notify the lactation consultant to come assist the patient with breastfeeding. So we would chart on how well mom's, how empowered she is, how confident she is, how the nipple is doing. And sometimes the baby just has a hard time latching on, and that also would need a lactation consultant to help baby latch on to mom. So those are some big assessments we do. Some of the education that we do on breastfeeding is when a patient comes in, one of the first things we ask them, are they going to breastfeed or formula feed? We no longer really call it bottle feed, because some women will put breast milk into the bottle as well. So the terminology would be breastfeeding or formula feeding. If they're not sure, we give them the benefits of both, or the benefits or the challenges of both. And of course, we tell them about huge initiatives and all the benefits of breastfeeding. When we talk about health promotion and disease prevention, beginning in this, preconception care and prenatal care, it also begins too, if a mom breastfeeds, that there's optimal outcomes, because breastfeeding has been shown to decrease obesity, to decrease chances of that baby getting diabetes, to decrease some certain cancers, respiratory infections, asthma, and for mom, it promotes bonding between mom and baby. It actually helps the uterus go back to its pre-pregnancy state. There's less bleeding. You'll get into your skinny jeans faster. So there's all kinds of benefits to breast milk. Breast milk is also constantly changing to meet the needs of the baby. When the baby is first born, what comes out is colostrum, which is this thick yellow substance. It's filled with antibodies and proteins. And it looks like it's not enough for the baby, but the baby at birth, the baby's stomach is the size of a marble. It doesn't need much, but it needs that colostrum, which actually gives it antibodies. And it also coats the intestines and gets the baby ready for the breast milk, when the breast milk will actually come in on day 3 or 4. So colostrum is a very important component. There are some cultures that consider colostrum the dirty milk. You can educate them on that, on the importance of the antibodies and everything else. But if for cultural reasons they decline, they want to wait till the white milk comes in, or the foremilk, then you would respect their cultural wishes. So We educate them that the baby doesn't need a whole much. A lot of women are concerned that, oh, my baby, I need to make sure that my baby gets enough. You know how mothers are. Did you get enough to eat? Do you need another hamburger? Do you want another glass of milk? Mothers are constantly concerned about baby's nutrition. So they're concerned that their baby's not getting enough if all they see is this yellow stuff and they don't see milk, that's something that looks like milk. Educate, educate, educate on how that is golden syrup for the baby, that is giving it antibodies and protein, which that baby needs. That breast milk is constantly changing because in 3 or 4 days, it's going to look like breast milk. But if you check the contents of it, it's going to be different. And then in 1 week versus 2 months and 3 months, it's always going to be constantly changing to meet the needs of the baby, which formula really doesn't do. But if you look at formula, they've caught on. Now they say this formula is best for the baby in the first week of life. This is best for whatever. So they're trying to mimic as best as possible. Now, if a patient can't or doesn't want to breastfeed, then, formula feeding is an excellent option for them. Some people, questions that women ask, of course, one of them is, well, there's no milk coming out. It's just this yellow stuff. Some people don't even see the colostrum. Then we help the woman express. We show them how to manually express, and they can see the colostrum. I've had women cry when they actually see that they can actually feed the baby and they actually can express something out themselves. So we encourage breastfeeding every couple of hours for the baby. We encourage breastfeeding within the first hour of life. We can assess to see if the baby is latching on. We can show mom expression and see so that they can see the colostrum. We educate them that the milk will come in day 3 or 4. Many women will say, well, how will I know when my milk comes in? And we'll say, oh, you'll know. It's called engorgement. The blood vessels in the lymphatic system, when the milk first comes in, becomes a little bit engorged or swollen, and it causes some discomfort when that first milk comes in. That engorgement period will last maybe 24 hours, maybe a little bit longer, but women are sometimes uncomfortable when the breasts fill up with milk. They feel very engorged, very heavy. The best thing you can do is feed the baby, and then you will become less engorged. I think if patients know what's happening, they're less fearful and they know it's the norm. The other thing people ask, well, will I constantly be dripping milk? Interesting enough, your body is smart. It fills up with milk, to feed the baby. In the very beginning, until it regulates, you might leak a little bit. We encourage people to wear breast pads so that they don't get they won't leak onto their shirts and have that wet t-shirt look. But eventually that leakage decreases. But what happens is the breasts fill up with milk and they don't just constantly drip. What happens is there's a letdown reflex. So if the baby starts sucking, oxytocin is relieved, which actually causes the milk to let down, and then it begins flowing for the baby. And initially it comes out and it really kind of sprays out. And if you look at the nipple, it's got it doesn't one stream, it sprays out. And it sprays out rather rapidly initially, and then it slows down. So if you've ever watched a breastfeeding mom, when they latch the baby on and the baby starts sucking and there's that letdown reflex, the baby kind of tries to catch up and it's and it, sometimes it pulls away and it gets sprayed, and then the flow slows down a little bit. So educate your patients on this. But there's other things that can cause a letdown reflex. If your breasts fill up like you're a nurse and you're working and you don't have time to pump and your breasts are really full and you hear a baby cry, sometimes that triggers the letdown reflex. So if you're out in public, we encourage breast pads because in case you accidentally bump into something with full breasts or you hear a baby cry, you may have that letdown reflex. But that letdown reflex is actually caused by oxytocin, again, that important hormone as well. Also, in sexual intercourse, sometimes the breasts are stimulated. If you like the spray, that's good. If not, breast pads during sexual intercourse might be your way to go. Other questions that people ask as far as breastfeeding goes, some people, sometimes the milk ducts get clogged up and they get a breast infection called mastitis. They'll know because they'll get a fever and pain. They'll call the doctor. The doctor will order antibiotics and encourage breastfeeding. It's not the milk that it's infected, it's the ducts around it, and you have to unclog them by breastfeeding and antibiotics. We try to keep our babies on a schedule. Usually they're going to feed every 2 to 3 hours in the hospital. if you don't breastfeed, what stimulates prolactin to make milk is baby sucking. So the more the baby sucks, the more that you make, the more milk you are going to make. Prolactin is the hormone that is responsible for that. That's why we say if you're not going to breastfeed, do not stimulate the breast, because that stimulation, even expressing or pumping milk, is stimulating the breast to make more milk. So that stimulation is really important. That's why we encourage moms not to formula feed in the first, until breastfeeding has established, which is about 4 weeks. And we say that for a couple of reasons. One is we don't want nipple confusion. The nipple on the breast is a little bit different than the ones that you get at Target or Walmart. If you go to the baby section, there's a whole aisle on nipples, and they all say, just like mom. I don't know how many Targets I've seen and how many Walmarts I've seen. I've seen the nipples for sale, and they do not look like mom's real nipple. They actually don't act the same, because when when a baby sucks on mom's nipple, it has to work pretty hard to get the milk out. It takes a lot of that lower jaw motion, and it actually is beneficial to the baby because it actually strengthens the jaw muscle, which promotes speech development, and it's better for the mouth. Versus the nipples that you buy at Target, the milk flows so much easier, so the baby doesn't have to work as hard for its milk. Babies are also smart. They're going to prefer the easy way out. So if you give them that Target nipple too quickly, or Walmart's nipple, the one that you bought at the store, they're going to prefer that nipple over mom's nipple because they get their food faster and easier, and babies are smart. So to prevent nipple confusion, pediatricians recommend, if you're going to have to end up, using a bottle to feed your baby breast milk, when you go back to work, wait till breastfeeding has established, and that takes about 4 weeks. Anybody who's going to breastfeed, I say you got to give it at least 2 weeks, because there are, some challenges with breastfeeding. One is the anxiety with it. Some women just get really anxious, even if it's a normal, natural event. Some women also, they actually might get nipple soreness, and sometimes the nipples crack. We give them a cream, Lancelin or Lancelot, to put on after they breastfeed, so that the nipples will not crack and be as sore. Sometimes people will ask, well, my grandmother told me to use some kind of natural potion that she used. And I would always encourage this. The doctor has ordered Lancelot or Lancelin, whatever the breast cream we give you in the hospital. I said, if you decide to use anything else, be sure to let your healthcare provider know, because whatever you're putting on your nipples, the baby is actually sucking as well. And I know that what we give in the hospital is good for the baby, but I'm not sure about whatever else they might use. So that little educational piece needs to be given. In addition to that educational piece, to prevent the nipple from getting sore, a good latch is really important, and that's why we assist moms on a good latch, meaning the baby not just grabs onto the nipple, but grabs onto the whole areola, which prevents the nipple from cracking. So a good latch is really important, and we educate our moms on that when the baby first latches on. A good latch will prevent soreness. It's not so much the on and off, not so much the time frame that you're breastfeeding. It's the on and off that actually gets the nipple sore too. But again, we encourage the lanolin and a good latch for that baby. When the baby breastfeeds on the right side, that breast is going to get stimulated and empty really the best, because the baby is hungry, more hungry when it first latches on. Therefore, we encourage mom, if she starts out breastfeeding on the right side, the next time to start on the left side, because that side will be more full and needs to be stimulated equally. And then, so whatever, we just kind of rotate sides. If they start out on the left side, then the next time they breastfeed, they're going to start on the right breast. It's just to make sure that they're equally stimulated. If you only breastfed on one breast, that the other one's not going to be stimulated, and only one breast will actually produce milk. So that's how important that stimulation is. In addition to that nipple confusion, some people will ask about pacifiers. The American Pediatric Association recognizes that there are a couple things that decrease the incidence of SIDS, sudden infant death syndrome. One of those is breastfeeding, so we highly encourage breastfeeding, but another one is pacifiers. So we encourage, we don't give babies pacifiers for one reason, until breastfeeding has been established, because we don't want to confuse the baby on nipples. But once breastfeeding has been established, American Pediatric Association say pacifiers are good to prevent SIDS. It is an individual thing. Some babies just they have more of a need to suck, and it's a patient's lifesaver. So if they ask for a pacifier or bring their own, they're more than welcome to use that pacifier. But if they ask me, I would say, well, the American Pediatric Association recommends it. It's an individual choice, but they don't want nipple confusion. So they say to wait till breastfeeding has been established. And that takes a while. Some women are, wonder if they're going to have enough to feed the baby. I say, if the stimulation, the more the baby eats, the more you make. There are growth spurts when the baby seems like they're eating all the time, but they're just stimulating the breasts and the breasts to make more milk, and eventually the breast will catch up. I'm not going to lie, there are some women who are like Jersey cows. They produce a lot of milk, and then there's others that produce barely enough for the baby, and there's others that work really hard. I do tell them 3 pointers to make as much milk as your body can. One, of course, is the stimulation from the baby, but another is to stay well hydrated. You need to drink a lot of water. Every time you breastfeed, you should be drinking water. And good nutrition is really important. When you're pregnant, your body needs an extra 300 calories a day to feed the baby, but when you're breastfeeding, it needs an additional 500 calories. Again, it gets the uterus back into shape, gets you into your skinny jeans faster. You can eat that extra 500 calories. Of course, don't waste it on donuts and non-nutritious foods, but lots of lean proteins and fruits and vegetables. So good nutrition and hydration is extremely important for the breastfeeding mom to be able to make enough breast milk for that baby. The American Pediatric Association recommends solely breastfeeding for the first 6 months of life. So most people will not introduce foods for the baby like cereal and baby food until at least after 6 months. Some doctors will recommend 4 to 6 months. But breast milk is all the baby needs those first 6 months of life. Then we slowly introduce foods. Most pediatricians will say after 1 year of life, you can wean them from the breast, because by then they're drinking out of a cup and able to take other sources of calcium and nutrients. That is a totally individual choice. There are some women who continue to breastfeed until the baby goes to kindergarten and beyond. Could be cultural. It could be a lot of things, but that's an individual choice. That's probably more than you wanted to hear on the first B, which is breastfeeding. But it is such a huge component of that postpartum or couplet experience. It requires probably the most education. The uterus, we've already talked about the assessment of the uterus. Where is it located? Is it nice and firm, or is it boggy? And also, which leads to the next one, which is bladder. We're concerned with keeping the bladder empty. If it's filling up, is it causing a displacement to the uterus? Keep it empty. Sometimes we have to catheterize them. Those people that have been catheterized during their labor are more likely to get a UTI as well, so we need to educate them on that as well. The next one is bowels. Most women will empty their bowels prior to delivery, but it usually they won't have their first bowel movement for a couple of days, and they're really worried because everything down there is a little bit sore. So what we do prophylactically is we encourage fluids and lots of fiber, but we also give them Colace. I always educate them on the importance of that. Some women will want to refuse it, and I will then tell them a story of a woman who did, because that first bowel movement can be pretty rough. Mostly after my story, they usually will take their Colace, drink plenty of fluids, and take their fiber. Also, when we're checking the bladder, we also need to check for hemorrhoids as well, because a lot of women get hemorrhoids when they're pregnant, and and then they will be more of a problem after pushing for a couple of hours, or some people will get hemorrhoids from pushing. The way we check for them is we actually check for hemorrhoids, and we check the perineal area for any kinds of bleeding or stitches or redness or swelling or infection by having the patient turn on their left side, lifting the cheek and taking a peek, and we can look for hemorrhoids and see the whole perineal area. And that would go with episiotomy area, which we'll talk about again in a little bit. So we need to check the assess and check the breasts, give education. We need to educate them on the uterus, be nice and firm. We pay attention to the bladder and the bell. The L is lochia. We've already talked about the lochia. You know, it's going to be lochia rubra, then serosa, then alba. In the hospital, you're going to see rubra. How much is too much? You shouldn't saturate more than a pad an hour. Those kind of things are educational for the patient as well as your assessment. The next E is for episiotomy. We've already talked about how a lot of women used to get an episiotomy. Now we encourage them, doctors, to be a little bit more patient, and midwives. So we're not seeing as many episiotomies, but we still see lacerations that needed repair work. And so we still need to check the perineum area. If they've had an episiotomy, a laceration, we still need to check to see if there's any signs of infection or anything. So again, we turn them on their side, lift the cheek, we take a peek, and we assess that area. Now, that perineal area, whether they've had any kind of a laceration or a episiotomy or anything, is going to be swollen after having a baby. We keep ice on that perineum area for 24 hours. It decreases the swelling and helps with the discomfort after delivery. After 24 hours, we can do sitz baths, which is just sitting on that's like a little bucket in the toilet, which has warm water, which provides warm, moist heat for healing after 24 hours. We also have a numbing spray, like a lidocaine spray, that we can have the patient spray on to numb the area. And we also have like an epifoam cream, which is like a steroidal cream, which decreases the swelling and promotes healing. A non-pharmacological natural thing that we can use is witch hazel, which is this. It's a natural ingredient, which is what we see in Tux pads. So we use those pads with witch hazel, and we put them on the perineal area because it decreases swelling and promotes comfort. We do that after pericare. Once they get up to the bathroom and they pee, we get the squirt bottle and we have them squirt front to back, front to back. For those of you who have been in simulation, I have showed you that. For those of you who haven't, I will show you when you come into the simulation room how we do pericare. There's a little bottle. I would say that anytime the first time patient is up to the bathroom, they need to go up with assistance, and they may have trouble peeing. So we sometimes turn on the water. We squirt a little bit of water on their leg from the bottle, and we can put peppermint oil into the toilet, which actually for some reason helps women pee. Once they pee, they rinse themselves with this little bottle of water that is lukewarm and tested on their wrist prior, front to back, and then they pat dry, and then they put on their perineal pads. So that's what we call perineal care, which is really important to decrease infection. We look for signs of infection. We check for odor, which is infection, but we keep that area nice and clean. The next H is for Hohenstein, and that's kind of controversial, but I would never take the H out of bubble heat, because our women, for the whole time they're pregnant, they've prepared their body for delivery. Their body knows that there's a chance of hemorrhage, and it has increased blood clotting factors. Because of those increased blood clotting factors, our women are more prone for blood clots. So the Hohenstein is just when you dorsiflex the foot and see if there's any pain in the calves, which would signal us to think, oh, maybe we better check for blood clots, do a Doppler study. Now, there's controversy over whether you do that Hohenstein and it breaks free that blood clot in the leg. So it's not so much that we do the Hohenstein, depending on your facility, but it's important to check the calves for redness, swelling, and pain. And if they have any of those factors, we would probably notify the healthcare provider, who would order a Doppler study to look for clots. Again, if your patient's having trouble breathing, it could be a pulmonary embolus, a blood clot in her lung, which would cause immediate notification of the physician. And if they're having trouble breathing, maybe even rapid response to that. So just know that with the H, the Hohenstein, we're just saying our women have an increased risk for blood clotting factors, including because of the increased blood clotting factors, they're more prone for clots. And then the last D is emotional status. We're basically checking to see how they're responding to the baby. Are they holding the baby? Are they calling the baby by name? Are they happy? There are some women, believe it or not, that do not want to hold the baby, look at the baby, or talk to the baby, or call the baby by name. That would signal something is emotionally wrong, and we need to check into that. We're also checking for postpartum mood disorders or depression. And because it is such a big topic, there's a whole other PowerPoint on emotional status. So that is your postpartum assessment in a nutshell, although you can see how very detailed it is because there's a lot that goes on in the postpartum period. Just remember, double E. So once the patient delivers, let's see what happens to the body. The cervix, okay, was once thick and closed. When the patient delivered, it opened up, and now it returns to its pre-pregnancy state. It will become closed, but the external os, it looks a little jagged after you've had a baby. So it never regains its pre-pregnancy appearance, meaning if you had a baby and you never told anybody, and then you went to the doctor and he looked at your cervix, you could probably tell that you've had a baby before because of the way the cervix appears. Again, it will close. It just doesn't have its original pre-pregnancy appearance. The vaginal and perineal area, once that placenta comes out, there's a decrease in estrogen, which causes some thinness of the vaginal mucosa and the absence of rugae. It's going to return to its pre-pregnancy state within 6 to 10 weeks after delivery. But what happens is the first time the patient has sexual intercourse, there may be some dryness and pain. So we encourage water-soluble lubricant during intercourse until it returns to the pre-pregnancy state. When can people return to sexual intercourse? For a normal vaginal delivery, usually it's 4 to 6 weeks once the patient is feeling better, but I can guarantee you if they're feeling better 2 to 3 weeks, they have no episiotomy and they're feeling really good, somebody else is too, so they're probably going to have sexual intercourse. The point being, if they don't want to have another baby before that baby turns a year old, you need to talk about birth control prior to discharge. Birth control, if they, if they were taking birth control pills, they may have to have a discussion because the hormones and breastfeeding. So that's a discussion that needs to happen prior to leaving. A woman who is breastfeeding, the body is producing prolactin, which actually decreases the chances of them having a period and actually ovulating, but it's no guarantee. If somebody is solely breastfeeding, they may not have a period for maybe as 4 to 6 months, but it does not necessarily guarantee that they will not ovulate. So they need to take precautions as